So we're in the final session this afternoon, and I'm going to just preface it with a little bit to set us up. And it's going to be about a lot of different things that we have been talking about today. And then we're going to open it up for discussion. And so actually, I'm going to come a little bit closer to the screen because there's some areas I want to highlight. But if you go forward to the first slide, Megan, this slide, I'm very, very happy of our FES Center illustrators who created this vision from my brain. And I showed it at STI 2020, but it really does, if you want to say it's from my perspective there, drowning in the wheelchair, but it's really our whole entire community that's out there trying to live day by day with a spinal cord injury. You really feel like all of these things are just kind of pulling you down and you can't win for losing. So this is what we're all talking about, the system being broken, that we're not really feeling the impact of research. We're not feeling, we feel like we're too small. We're not important enough to industry, and we feel drowned in the healthcare system. So what are we really going to do to try to change this from our communities side of things? So we go to the next slide. I want to really talk about what is translation, because you can talk to different people and it means different things. And the points on the right-hand side here. First, translational research encourages and promotes multidisciplinary collaboration among laboratory and clinical researchers. It incorporates the desires of the general public, with communities being engaged to determine their needs for health innovation. And it identifies and it supports the adoption of best medical and health practices. So I want to spend a little bit of time on this picture right here. This is really what translation is. It's got 5 different stages, and it goes from the academician all the way out to the community. So T0 right here, this is the phase of basic research. This is where discovery research is. And each of these phases of research is very important. It's critical. So we need T0, we need basic research. The next phase is T1, which it says preclinical studies up above there, and it says translation to humans. This is actually different than innovative basic research. It's actually pretty difficult for basic scientists to get preclinical research studies funded because reviewers think it's boring. This is where you're talking about dose effectiveness, what's the right amount, what's the right dose of rehab, what's the right dose of a drug, what's the right time that you give it to the animal or the human, all of these things that you really need to know to be successful in the next phase, which is T2, and you're going to clinical trials, but it's actually really hard to get funded in T1. Okay. T2 is actually straddling clinical efficacy and clinical effectiveness. So clinical efficacy is clinical trials, phase 1, 2, 3, or early feasibility and pivotal for devices. And this is where you're in that really narrow population of people and you show benefit in that narrow population. That's efficacy. Effectiveness, and this is usually when you get FDA approval, then you can go and do what's called phase 4 studies in drugs. That's where you're administering the drug out to a larger population that is not restricted to the inclusion and exclusion criteria of the trials. And then you're looking at how effective this is in that broader population. Sometimes you do comparative effectiveness trials where you're comparing the new intervention to the standard intervention, and you see if the new intervention is superior in some way. That is clinical effectiveness. And then T3 is actually translation to practice. This is where it takes dissemination and it starts to take implementation research to translate this new approved drug or device into the real clinical practice, and then implementation research involves basically its behavior change, because you have to start changing the behavior of the people that are in the healthcare systems and the actual healthcare systems themselves to take up new information, new medical information. And then that starts to be taken up in more and more communities, and it kind of translates to T4, which is translation to communities, and that's where you actually have impact. So if you go forward one, Megan, in spinal cord injury, we've got a wealth of knowledge and a wealth of investment in T0, basic research. And if you go one more time, we have a pretty good body of knowledge at T2 clinical efficacy. It's difficult to perhaps get access to clinical trials because they're tight inclusion and exclusion criteria. But if you think about over the last 30 years that I've been injured, there weren't any clinical trials back then, except there was the methylprednisolone trials were going on, and I didn't even know a clue about them. But you could actually go in, you can identify a lot of clinical trials that are in this clinical efficacy area. If you go forward one more, it's a big black box. What is happening in the STI research and healthcare community about T3 and T4 translational research to practice into communities? And there's funding out there for it, but there's not as many people that are out there doing it. So if you go forward one more time, the key to success is really this knowledge exchange and partnership. And across that entire spectrum, there's a lot of different players. And so if we are on the community side, my challenge to think about today, what can we do to start pulling things from T0 and T1 and T2? How can we pull them to make them out to T4 to answer the problems that people are telling us that they're facing on a daily basis? So when we talk about translation, it's all of these things. If you go forward to the next slide, this is talking about where is STI research, and there, if you go forward one, there's a circle that'll come up. This area of STI research we're really good at. Research knowledge users develop questions and methods. They conduct the research, they get research findings, they publish it, the publication feeds back into the next grant. And if you go forward one more time, we as a STI community are starting to add impact on designing the research question and methods, and we're starting to add impact on conducting the research. That's a lot of what we talked about already, and we're building strategies to build capacity in those areas. But what happens with this endless cycle? And KT here, the initial KT stands for knowledge translation. And everywhere that you see a KT is a potential for knowledge to be translated to another area or another group or another place in the cycle. And if you go forward one, there are some areas that are right there, right here. Publishing the research results in plain language and in accessible formats. To me, that seems like one of the lowest hanging fruits that our community could actually start working on. We can go through and if we take what our community has said, they've got major problems with bladder, bowel, pain, and care of all kinds. We could actually start scouring through the literature, finding publications on say, bladder care, and we could actually start writing lay language summaries of those. We could maybe do, so Dale mentioned earlier about YouTube as a format. I know you can do those little caricature things, or you could have somebody speaking like a 2 or 3 minute summary of what does this mean and start collecting it in one area. That's the lowest hanging fruit. If you go forward one more, This is pointing at placing research findings in the context of other knowledge and sociocultural norms. So really taking a collective group of research findings and, okay, thinking about it, what does that mean in the real world of life with spinal cord injury? How can we try to contextualize that? And then lastly, one of the hardest things I think is, if you go forward one, as you notice, the arrows get darker as we go. That's supposed to be intensity of challenge. Going from contextualizing knowledge to actual application of knowledge. And that is where you make decisions and you start to take action informed on the collective contextualized research information. And this might be where actually healthcare providers can start helping us in, if we have a collective of information on bladder care in one aspect, okay, what of this information can we start taking action on in a clinical way to help putting it through the real world evidence and into the communities? What information are we missing? What area of research in the real world practice do we now need to get funding for, help get funding for, to start to move it into T3 area of research into practice? What limitations are there in the healthcare system today that would prevent you from doing this in your clinical care? So I think this is our end goal, but we need to start thinking about, we're really, really good in this green area, and we can easily start to make that information in lay language. But how can we try to start to go along the rest of the research cycle? And go forward one more. With our guiding light being what the community is telling us their problems are. That's because there's a wealth of information we could start there. We could so easily be overwhelmed just right now. So let's be guided by the problems that people are facing. And the last slide, if you go forward, is what do we want to do from here? Who is responsible for distilling this information and recommending that something move to a different stage of translation? And the honest reality is that no one is responsible, absolutely no one. That no one can be blamed. It's a huge, huge process. And not one person, not one specialty of people can specialize in this whole process. It's just impossible. So what do we want to try to do collectively to go forward one more time to start to, yes, to start to connect the dots here? And this is the theme that NASCIC has really been talking and discussing amongst the Executive Council and our members over the last year. You know, really, what is our identity? What is our role in this space? And we really want to just be, we want to be connecting the dots. We want to find out, okay, this information is here, but that person is over there trying to do that. And how can we facilitate this whole thing? And then the last point here, I just want to reiterate that can guide us for the discussion is, let's be guided by our community. And it's not just me, and it's not just Barry, and it's not just Bill back there. It's everybody that we're interacting with on a daily basis in our different organizations. So with that, I want to open up for discussion. And let me just say, I don't expect us to solve all the problems today, but just by talking about ideas or talking about problems in the system can help us spark innovation in that way. Taryn.
So I'm very excited by all the discussions today and this graphic that you've just shown now. But I'm also feeling a real tension inside because what I've observed in terms of successful community engagement and not is that the people that are able to engage from our SCI community back home are those who have resources, and it really makes up just maybe 40% of that population. And so they may be the ones who get involved in the few clinical trials that are available. They certainly are the ones that get involved in advocacy and peer networks and really engage. But I worry about that other 60% and how we can do a better job of hearing their voice and getting them engaged, because it's just so much more difficult for them because of where they live, their access or lack of access to good housing, to good transportation. So just want to kind of flag that in terms of strategies moving forward, if we can think about ways to engage them more successfully.
I agree, 110,000%. Matthew?
I agree too, but I want to be careful, and maybe this me personally. We were actually talking about this last night a little bit. Every now and then, I connect with somebody who's in a rural nursing home, and the place she left, they didn't give her a power chair, so she's been in bed for 10 weeks, you know, or somebody's in a group home who needs to get out of that group home. These are people who are lost and left behind. And every time that happens, I'm, you know, because I'm a human being, I'm like, oh, I could fix this. But it would be 20 hours a week. I'm your new case manager, and we'll fix it in a few months. Like, we'll get you square, but I can't. And so I fully agree. And I'm also sort of like being pragmatic, and I'm being like a triage nurse. I know your tooth hurts, but that guy with the chest pain is going in front of you, you know? So, I mean, I didn't answer anything. I think we all agree, but we have to be careful of how much resources and how much capacity we have.
Good. You want to respond, Taryn? Mm-hmm.
So perhaps one of the ways that we can try and capture that situation is through data collection through the community organizations.
I was just going to say that.
Yeah.
Yes. Yes. That is our strength, that the community organizations are the ones that are able to interact with those people right there. Okay. What can we actually, like Dr. Darrow said, every amount of data is valuable. So what can we get from them that can help make their voice heard out on the other end with a larger number of people?
And how can we kind of standardize how we collect that information in the community? Because right now, I think we all do it in a bit different
ways.
Yeah.
Yeah. Actually, I think we have a comment from online first, and then we'll come to Jane.
Oh, we just got another comment. We got one and then another one. So this one's from Anita. What I've been hearing from the research community is that they have a hard time getting funding for translation/implementation research. A lot of funds are devoted to innovation. So maybe the SCI community needs to have conversations with funders and strongly advocate in partnership with our researchers to get these projects funded.
Yeah, so we could actually collectively try to advocate for a larger portion of funding that can enable SCI implementation and dissemination research at the T3 and the T4 level. That's a good point.
And another comment here from Heather Gainforth. If we think about integrated knowledge translation as the meaningful engagement of the right research user at the right time, is that we need to help research teams think about who is your research user. For the T0 basic researcher, their research users are likely another T1 translation to humans researcher in addition to other groups. Therefore, I think we need to think about how we build meaningful partnerships on only between researchers and the SCI community, but also between researchers and other researchers that can inform, take up, and apply that research to the next stage in the process. I also think Matthew and Taryn make an excellent point that we need to ensure that when we help build these partnerships, we look for efficiencies and we are careful to ensure our solutions do not create burnout for the researchers or research users.
Yes, I agree with that. And I think maybe some people in the STI community might think that researchers are only the basic scientists and the clinical trial people. But actually, there are researchers at the T2, T3, and T4. It's all research. And so we need to help all different researchers, and they are different people at those different stages, and they are different research users at those different stages as well. Jane.
Yes, I just wanted to mention something to Terrence's point about engaging people who may be having less access. United Spinal has begun a project that is a NASCIC project to develop some data points for the CDC is now going to fund, develop a neurological surveillance system, neurological condition surveillance system. And right now they're piloting it with people with multiple sclerosis and Parkinson's disease. And we're hoping to ensure that spinal cord injury is included in that, so we can gather data more broadly from all people with spinal cord injury to make sure we capture all the cases. So that's one thing going on. But I also just wanted to mention, you know, I think you said that we had about 200 or, no, I'm not sure how many people we had join a participant database for being part of projects.
There's 46 people actively in the engagement database right now.
And maybe that would be an area we can be sure to engage people who, or, you know, maybe work on our efforts to engage people from rural areas and people with less access. And just United Spinal Association, we are always hoping to, you know, we have our programs and newsletters and magazines to help keep people informed of what's going on. So.
Barry has a comment up there.
Thanks. I'm just looking at your diagram, and I think of the many years that we've been in this space trying to connect the dots. And I think of an obvious one, and maybe it's naive of me to mention this again, and I'm saying it for years, but is this not like the way pharma would act? You have a concept, you move it along, the famous pipeline, and then it's ready for market. Is that not what pharma does? What private industry does? Yeah.
When it works.
Right. I've seen it work. Okay, but so why don't we do that? Why don't we take that? I'm not saying everything's a for-profit adventure, but as a quote, maybe a stewardship of sorts, why don't we take that concept and look at some of the models and mechanisms that are used within private industry and taking something from bench to bedside from the beginning to the end and apply it this way. But of course, finding a way that we can bridge the gaps, because all these components from T0 to T4 aren't necessarily owned by one entity.
None of them are owned by one entity.
That's right. So who owns it? So
Right.
the question is, someone's got to own it, and maybe not own it in a literal sense, but maybe it's the community has to take ownership of it and mimic what private industry does to bring it from bench to bedside. It sounds simplistic when I say it like that, and I know it's a hell of a lot harder than that, but the model's out there. My point is that private industry has been doing it for years. That's what they do. And why can't we somehow adopt some of those practices and do the same thing?
I think Megan has a question, and I'd like to make a comment while she's getting the microphone. I saw Kimberly back there. She said it takes money to do that. Yeah. But also, maybe this is what you're going to talk about, Megan, from your cardiovascular days, is how once pharma has something approved, well, that's not the magic answer. How do we get to T3 and T4?
Yeah, well, that is a good, question as well. I think I was kind of thinking that at least in the medical device space, a lot of companies don't innovate. Innovation actually does really occur in academia and people exploring new ideas and whatever. And then if it's exciting and the market looks big enough, a bigger company will swoop in or either the investigators will spin out a company, or they'll start it off and like give a license to somebody else to start a small company. That company will take it to the next level, and then a bigger company will come and acquire them, and that's how the money goes, right? So to replicate it, I don't know how it works on the pharma side, but at least on the device side, it really does come down to the money and how it gets handed off and how you can create monetary value at each of those stages. So just to bring it back, at least on the device side for neuroprosthetics, what we're trying to do is incubate things longer in academia so that we've de-risked the pathway a little bit further, so that when an industry partner comes along, they don't have to do quite as much to get it to the next level. That's sort of our theory of operation.
And I've heard you talk about, Megan, in the cardiovascular medical device field, there's a strong pull from clinicians on the market to bring, there's a high demand for new technology.
Yeah.
Can you explain that?
I can. So ages ago, they stopped trying to fix the heart by giving it drugs and biologics, and now they just put a stent in, or a new valve, or a new pacemaker. And so the medical device industry for cardiovascular products is really, really robust. And so the clinicians want the next tool. They want the next greatest tool. They're used to having tools coming onto the, out of the pipeline pretty regularly. So that pull is really, really there. And so they're the ones putting demand on the system. The companies then iterate on their new pacemaker. They bring out a new pacemaker every 6 months and give them the newest bells and whistles. And so there's that expectation by the clinical community that they get to play with the latest tools. So I feel like potentially in this community, the clinicians don't have a lot of tools, and they're not expecting a lot of tools, and so they're not really demanding for things to be coming through, and so that pipeline hasn't really gotten robust, but it could be.
I just want to make a quick comment on what Barry said, and then Megan, what you followed up with. That idea isn't new. And there's a handful of people I know of right now that are either trying to or wish to do just that. Open up their own shop, their own contract research organization, like Vance Lemon said in his opinion piece about STI 2020 to us. If the STI community wants to take charge, then they should do a top-down approach and make their own CRO and take the whole thing from beginning to end and attract the VC, et cetera, because we don't have what you just described, Megan, obviously. And those people are out there, and those people are saying, they're the people in the SCI community are saying the system is, I don't trust it. I'm not looking, I'm not paying attention to it anymore. I'm going to put my resources into creating a tool, a house to take discovery to the clinic, because that's the only way it's going to happen. And they're impatient for relationship building, and they're impatient to go after the clinical community to create the pull. It's like everything is like, I'm waiting on somebody else. And so they're like, forget it. Let's just do it. But,
And operating by yourself only lasts for so long. Operating by yourself only lasts for so long. Actually, Christy and Marianne, can I get you two to comment from the healthcare provider side and the spinal cord injury specialized healthcare provider side on maybe what have you seen from research in the last 30 years, or what haven't you seen?
Well, a couple comments. You have who is responsible for distilling information. I think it's the clinician's responsibility to help push that along. I think of the guidelines for DVT prophylaxis that had changed for a while. We had the consortium guidelines that were out. We actually had to lobby them to pull them because they were erroneous. Consumers and guidelines to clinicians. So we are responsible for helping move around, educating the patient, advocating as well. I think our task right now is, you said there's like a pull factor. Bowel care, looking at bowel care. We're up against right now getting decent bowel care into the home. The time for people to do bowel care is enormous. Getting skilled people in is a challenge for us. I'd like to shorten it up. I'd like to give more independence. So there's my pull, but I don't have a large enough audience for that. So But who's responsible? I think the clinicians at the bedside.
And what
I do.
about the SCI professional clinical societies?
Oh, as well. So we have a number of those as well. Pushing along best practices, looking at clinical evidence, many of those. So that's our goal. And just something on the consumer guidelines. They're out there. I'm on that consortium right now too, and there's been a stall with the PVA, but I think those guidelines, the consumer guidelines, are helpful for patient information, just in general. So, Chris, you want to comment?
So what I personally see and struggle with in terms of getting new ideas, and they may not even be new ideas, they may be things that are just gathering evidence over time, is that while I can make a recommendation, I can't necessarily get a therapist or a nurse to implement what I'm doing or what I want to do and what the patient may want them to do. So I think that there is just a huge need for more education. And I believe that in many cases, if you don't have say a corporate or commercial partner that can bring in educators. So for example, if a company wants to bring their product into RVA, they have to bring in their representative who then has to educate. And then there's this distrust because people are, oh, you just want to sell us something. You just want to get our money. And so I don't know what the answer is in terms of bringing the evidence in a non-commercially biased way, because when the commercial partners bring it in, then, for example, we have something we want to bring into our outpatient practice for bowels. And the nurses are like, well, yeah, I don't they were literally during the presentation. And so I struggle with how to do that. And I think that it does, like Dr. Richmond said, I think a lot falls on the physicians to bring the new research in. And so the more that the associations, Asia and ASCIP, for example, are bringing the science to the general practitioner, the more that it's going to be seen as a non-biased partner driving that this is something new that needs to be changed.
So for example, one thing might be if Asia or ASCIP or both were to collectively look at all the evidence that's out there for exoskeletons, and not just one, but any of them, and collectively say, this seems good for this seems good for that, doesn't seem good for this, whatever. Then, and that is a white paper on their opinion on the clinical evidence of exoskeletons, then they're not just recommending one or the other, it's about the topic in general. But then that also leads to the hesitancy, probably, and as a researcher, you tend to do this, but we don't know enough. So we don't have enough evidence to say this. Well, what is enough? And that's where the struggle of people with spinal cord injury come from. What is enough? Actually, John first and then Megan. Oh, okay.
Oh, okay. Yeah, back to like the evidence piece. I mean, maybe I'm biased because they came from the FDA, but they look at a ton of evidence when they make their approval decision. Why isn't that enough? Why do you have to go and do more studies? Like, why? I'm actually saddened by the idea that like a company could come in and show you some great new way of doing like bowel management or whatever, and having the clinicians not be trusting that might be the state of the art thinking, right? How else is innovation in the clinical setting supposed to happen if people aren't going to be swayed by the same evidence that swayed the FDA?
John, yeah.
So what if there were this radical idea that if I have my own evidence and any other pacing company might have theirs, or exoskeleton companies, what if we're at Asia next year and put them on the stage together with the people presenting exoskeleton data, and people all get to see it and show it, and clinicians get to have this top-down approach to say, oh, I like that option versus that option, and then we're actually partners instead of adversaries.
That's actually a great idea.
It's amazing how much effort it takes to get people to walk through an exhibit hall and actually engage with somebody. So it'd be super cool if you could get that with the 600 people or the 1,000 people that are there and paying to attend so they can get this kind of information rather than going out of their way to like engage with me as one person and I have that audience and that's it. Now they've got the whole room.
And the reality is that healthcare providers need options, and people with spinal cord injury need options because we're all different. And one device may be good for this type of people, and the other one may be good for that type of people. And that's really important for healthcare providers to know and see.
John, John, really
your
good point,
daughter's
but
interrupted.
if I can take it one step further, you know, I live in the device world of innovation, and I mean, how many companies do we know in this room that are in that pipeline right now, trying to translate out of research into the marketplace, and it's tough for them. So why don't we identify those companies and help marshal them along? Because biggest problems I hear in investor meetings is that for those commercial ventures to try to get into the clinic, that's a real challenge, to be able to get the adoption in the clinic and then being able to find that end user. I mean, that's the world you live in. But I also wanted to comment on the earlier question of these Me Too products. So, I mean, it's a bit of a pessimistic view of the commercial side, but a lot of these Me Too products that come out, or Me Too pharma that comes out, is a lot of it's centered around IP and patents that expire. So we also have to think about that, you know, important piece of intellectual property that happens on the commercial space.
Did you? Let's bring the microphone to Christy and then back to Matthew.
Okay. So I think that the piece of what Kim was just saying about different patients, different needs, and also different access based on what their insurance is or who's their provider. And I think that's where I really feel like there ought to be a more centralized solution.
Okay.
Providing this for our patients.
Access. Matthew, do you have? I want to bring up another topic after you.
Okay.
Yeah.
Well, mine is another metaphor, sorry.
Oh, come on, Matthew, say something concrete.
Well, again, I keep thinking like this is like we're the kids from the poor school trying to get to nationals with our marching band, and we're really pissed off at the kids from the rich school because they don't have to think about any of the things that we're talking about. And where that came from is, you know, I used to manage an ER, and it was so many years ago. It was in the days when I can remember the rep coming in with like 8 pizzas and a 24-pack of Coke and pens and trinkets. And, you know, that was back in the day when our break room, like every other day, was full of food and candy and tchotchke to sell something. Some drug, some cardiac drugs, some stroke drugs, whatever in the ER. And so in some ways, like I know it would present different problems, but it is sort of that simple. Like there is nobody doing that for us. There is nobody who's invested with enough resources to give us all new trombones and nice shiny uniforms, like to grease the wheels. And so we really have to creatively do it ourselves.
Okay. John?
And I think part of what you're saying there is an issue that I run into because the standards of care just don't change that rapidly. They're so slow in picking something up, and everybody is set in their ways. And those ways are different when you're in New York or San Diego, and sometimes they're completely opposite of the person you talked to 15 minutes ago. So nobody is on the same page when it comes to what they're doing for one patient versus another, even though they may have the same level of injury, same mechanism of injury, anything.
So this brings up a topic, and I don't want to pick on the 2 physiatrists in the room, but I'm going to, because I know you guys have tough skin. And I'm not saying that you guys are this stereotype, but there is a stereotype that many people think of, and they say that SCI physiatrists are too protective of their patients that they don't want to take anything up. They're too paternalistic. They don't want to, it's almost like, crossing your arms kind of thing. And I know that that's changing, but there has been an old school like that. What can we do that might help change that situation?
So just for the record, Dr. Richmond's an internist. Okay. so I'll take this.
So it's all on you, Christy. Yeah.
Right. So I know what you're talking about, and I think that it's not just physiatry that suffers from this. It's also therapists. It's also nursing.
Mm-hmm.
I see it in even amongst pharmacists sometimes, and I really think this comes down to a lack of respect for patient autonomy. So I think that more education about autonomy is critically important, because I run up against this sometimes when I want to do something different and the patient wants to try it and people are like, oh, how can you do that? And I said, well, it's their choice. I have given them the best of my knowledge about the benefits and the risks, and that patient gets to make that choice for themselves. But really, I think this would be a great topic even for like an ASCIP or an Asia conference,
Mm-hmm.
would be to talk about patient autonomy, which then could be a bioethics, discussion. So talking about the bioethics of autonomy in the context of scientific research would probably be a great way to start bringing that to people's awareness better. Because I know people know it,
Yeah.
but do they practice it? And then there's also the fear, right? So there's the fear of litigation and of being sued for malpractice. And I think that ultimately your relationship with your patient or your research participant is critically important, so that people have these discussions about risks and benefits, and that the families also are involved and understand how the person came to the decision that they made. And that's another, that's basic medical education.
And shared decision-making is becoming a very
It's a
big,
hot topic. Yes.
So it's not just engagement in research, it's the
Mhm.
same thing, shared decision-making in healthcare.
Again, I think it's this, so the physician being current and well-read, understands the research, understands the evidence, and bringing it to their practice. We discuss new research. We bring new programs out based on that. But you have to you have to understand how to read research, literature, and bring it forward. You just have to be a driver of that, your group.
And you have to not be afraid to say, oh, I don't know anything about that. Let me get back to you.
Mm-hmm. Mm-hmm. So that's actually maybe something that we could start to think about as an organization, is not only interacting with the multiple industry companies that are maybe similar devices and getting information there, but partnering with local healthcare providers, and that we could create, summaries of research and say, okay, and partner, have a person with spinal cord injury come in and talk with the whole group and say, look, this is this is the clinical knowledge. This is what people with spinal cord injury think. What do we know about this? What are your concerns? To try to help break down that barrier.
I really appreciate what you said. At the same time, from personal experience and even back to my ER days, I do think that there is rampant paternalism in the healthcare system. The hierarchy is tilted, and there are biases within the healthcare system that I've experienced with my son personally. I don't know, well over 100 times of this, what I would not expect, but it's like a physician similarly to a waitress, like, oh, what's he gonna have? Like, well, you could ask him. that kind of dynamic is rampant. And I do think it's problematic, especially when, the point you made about staying up to date and being well read and understand what's going on, because the system is demanding that you also be an educator. And it takes me back to my ER experience days that very few people in our ER, physician, nurse, tech, nursing assistant, were educators. They stuck in their lingo. They didn't explain anything to anybody. And it was a real pet peeve of mine, because they're the people who think the system works and you just go sit here and I'll take care of everything. Instead of realizing I have to explain what this test is, where you're going to go, what's going to happen then, what it's going to show us or not show us, and help unpack it. And I know personally, in my experience traveling through that system, that same system with my son, it's not that great in that regard. It's really not. And so it's a piece we have to address and improve.
I might bring up another topic if we don't have any more on that. And we still have a couple of industry representatives here, and it's something that came up on the needs assessment survey, which is related to getting better reimbursement for things, whether it's therapy, adaptive fitness, assistive technology, home healthcare aids. And at Working to Walk, we had Susan Miller from the coverage side of CMS. And it's probably the most daunting monster that anybody in this room, it's probably the bane of your existence in the industry. And it's a constant battle. And we feel it every single time we try to get something reimbursed, whether it's even just a particular kind of care. For me last year. And so, and one of the things you see is you get these denial letters from different insurance, and it's private insurance too. Private insurance may be worse, but there's, denied for lack of evidence, or denied for you didn't do this kind of test first, and you didn't show you failed on this and this and this, and so we're going to just deny you. What can we collectively do to gather the evidence to help try to support reimbursement decisions? Megan.
I think this could be, well, if we could start by being guided by the community and picking specific examples around bladder, bowel care or pain. But maybe I did see this one group that is doing a podcast on this, but they're just collecting people's charges and bills and analyzing them for what was covered, what was not covered, and a picture started to emerge. So you might not want to do something quite that intrusive, but you might want to get like case examples and then try to describe like what the common either denial patterns are or whatever to make a clearer picture. Is probably one of these things where everyone's got an anecdote and everyone's anecdote is very, very similar, or constellations or patterns of denial reasons are going to start to emerge, and then maybe start to shore up or identify solutions that address specific challenge areas. And that might be a good model for all the things that we're talking about. We might want a couple of test cases that we just push out, see how things failed, and then analyze the patterns and the reasons for failure to get at a more granular set of solutions to it.
Another thought could be we could develop better, robust guidelines with better algorithms too.
Okay.
That we develop as we develop. So
that's good.
They utilize our guidelines, our algorithms.
Can I ask some of our Canadian representatives, because we think that you guys are in Wonderland with social health care. Can you tell us what problems that you do experience? Taryn?
If I can address something right before that, and I'll give it to Terry.
Okay.
So I'm generally a pretty optimistic person, but I'm just convinced sitting here today that that 20-minute or whatever time we had Dr. Miller address us remotely is just 20 minutes I'll never get back in my life. And it was political, it was bureaucratic, it was the party line. Much of it was straight out lies. And so that's what you're dealing with. I know we have to entertain the FDA and CMS as part of the process. You know, whether we like what they said yesterday or not, we have to not engage them. But in my probably limited experience, I've been a few times where in the policy department, I had several of us from the organization come and accompany the policy directors to the CMS meetings, first in DC and then their Grand Poobah headquarters in Baltimore. They didn't care at all. And we first meetings were, show us the data. We came back and we showed them data. They still didn't care about data. The only thing that I have seen work with CMS at all is ignoring them and go to Congress and get them to fix it.
Yeah.
Congress does listen to us.
Yeah.
CMS does not, in my opinion.
Can we get some of the Canadians' perspective before we go onto that as a larger topic? Yeah.
So most health, medical assistance, social service programs are provided at the level of the provincial government. So a key problem is it looks different in each province. And if you move from one province to another, you basically start over again. So that's a challenge. In my province in Alberta, some of the programs that are relevant to people with spinal cord injury are located within the Ministry of Community and Social Services. Some are located within health. And everybody takes the approach of funder of last resort. The exception would be the Workers' Compensation Board. So if you're injured at work, you get the right equipment at the right time, you get through rehab in a timely way and back into the community in a timely way. You know, they're the perfect example. But if you happen to have a ski injury, for example, it is a fight every step of the way. Eventually, you probably will get the funding that's available through our government system, but it's not without having to go through 2 or 3 appeals. And we're trying to, we're working on a new model of care for our province for spinal cord injury. We're trying to get health economists involved to map out the dollars that are wasted in terms of people needing to stay in the rehab facility longer, or people going from acute care to long-term care while they're waiting for the rehab bed, people waiting to get the right equipment because of everybody, well, I'm not going to pay because they might pay, mapping out the wasted dollars and seeing if it can't be reinvested into getting people the right service, the right equipment at the right time.
Okay.
So it's not perfect.
And Barry, you're representing Ontario, and then we'll go to BC.
Where?
Up here first. Yeah. Mom.
No?
Up here.
Thank you. My slant is just a tad different, and I agree completely with what Taryn was saying. It's the same in Ontario, but we have to remember that our program, which we call ADP, Adaptable Devices Program, which would be akin to what CMS is in certain ways, is a huge funder for the industry too. So when it goes awry, so does the industry, and it is not in our best interest to have an unhealthy industry that we have, because we lose innovation. And when we talk about products that could help people with like mobility devices that can help people with spinal cord injury, innovation is lost when margins are lost. And I have a close relationship with more people on the retail side. So the one below, you know, the people that are actually selling the chairs on the ground level and things like that. And they say, Barry, there's no margins anymore. You drop sales staff. There is nothing out there, and we can't even do a loaner chair anymore and how do you talk about building your 3-page list of what you need. You find someone that doesn't have, say, someone as long in the tooth as you or experienced, and they got to choose a power chair, but they can't even borrow one or try one out. That's a disaster waiting to happen. And that's where it's all becoming unhealthy. And I think as a suggestion and an outcome out of this thing is we need to partner with the industry more as consumers and the industry to go back to the CMSs and the ADPs of the world and say, you're messing this thing up. Because at the end of the day, when you go out and Permobil puts through a $35,000 power chair, that's wrong. And this person might not have another kick at the can for how many years. This is all just wrong. And that's when it becomes inefficient. So I'm just trying to put it through a different lens when we look at this thing, is that's something that we need to work on too, is working in a partnership with the industry when it comes to these things.
And then we'll take it over to John at the back table.
So I'm just going to give a little bit of my perspective, and then I'm going to hand off to Terry to give her perspective, because I think she sees things a lot that I don't see. I think that, you know, in BC, and I think in a lot of Canada, because as a national organization, we kind of get a chance to look in at a variety of different places. I think Taryn really hit the nail on the head in that, you know, our health delivery system is, you know, set up on a province by province basis. So each state or province sort of delivers it in the way they see best. There's different tiers of care delivery. So dependent on how you're injured, if you've got a motor vehicle accident, you get a nice big insurance settlement. If you had a workplace injury, that's your golden ticket, because they are very good at taking care of people that have workplace injuries, and really are working towards preventative models, not waiting for problems to happen, which is absolutely fantastic. The automobile insurer in British Columbia, it's a provincial system, is also looking to move towards preventative maintenance and long-term care type setup as opposed to a singular payout. But yeah, if you're outside of those two models of injury and it's happening recreationally, you're at the bottom tier. You know, you've still got social ministry support, but it's slow, it's complicated. And people really don't know how to navigate it. And that's probably the biggest challenge. You know, you talk, Barry says about getting a new chair. You know, if you're reliant on somebody to help design and get a new chair for you, you're not familiar with them, you know, you get into a crappy chair, it's a 5-year wait minimum to get a new chair. And that means 5 years you're sitting in a chair that's terrible for you. And we see it discharge all the time, you know. When it comes to medications and things like that, you know, sometimes you really got to fight. You've got to be your own self-advocate. And if you don't know how that system works and how to get through to approval, you know, a lot of people just fall between the cracks and don't know what to do, and they get frustrated. So I think probably the thing we need more than anything is navigators to help people understand how to get through the system and how to self-advocate or have somebody advocate for them. But we're definitely working towards improving the system nationally. We have a system in Canada called Accreditation Canada that accreditates all the hospitals and rehab centers across the country. We set up the SCI standards with them in 2010, and now we're working with them to do much more robust prescriptive standards for acute rehab and community care. And I really hope that that's going to change the system across the country in one fell swoop. And really make a huge impact. So for all the people that are representing Canadian community organizations across the country, there'll be a survey that we're going to be sending out in the next couple of days. Please send it out to your community, send it out to your people, because the more people with spinal cord injury that inform that survey, the more we can ensure that their voices are heard and that the system changes to work for them.
Terry?
I won't add too much, but one thing for car insurance, there is, unless you have a tort claim, there's a $300,000 cap in BC. So that's about, I mean, that's better than having, as John said, a recreational accident where you become spinal cord injured. The arm ministry, you have basically no choice. They have huge limitations as to what wheelchair you get. There's also, you know, they won't do any renovations, and essentially you have to be a person on welfare in order to get anything. So if you do any work at all, and our housing, especially in Vancouver, is out of control, and you have to essentially have two incomes in order to have a house. You have to have no assets. You have to live in social housing. You have to be designated as a person with disability, which essentially means, you know, you're on welfare, and people can't live like that. We don't have any catheter coverage, so we have to pay for catheters. And even long-term insurance plans, again, it goes back to the same. You got to fight. In my situation, they told me that we wouldn't pay for anything unless it cures you. Well, okay, great. You can put all your money into spinal cord injury research then, because, but this was, you know, 24 years ago, right? It's the same thing that happens today that I see with clients all the time going through. So it's definitely a struggle.
So in the US, we do have a lot of people are either on the state Medicaid program as an interim to getting, it's a long wait to get on the Medicare program, which is federal. But you've got all of those income restrictions, and you can't live on what they say your cap on your disposable assets is. And so I think we have different systems, and we have some commonalities.
So I've got one more element I forgot to add in my little bit there, was that one of the huge problems I find in our community is the disincentives to return to work.
Yeah.
You know, a lot of people with spinal cord injuries want to be active and working and generating their own income. But, you know, if you're on workers' compensation and you attempt to return to work, you know, you don't know after a spinal cord injury if you can go back to working 40 hours a week. You don't know if you can work 20 hours a week. But as soon as you cross a certain threshold, they say you're capable of working, you're cut off. And same with welfare. You know, if you want to try to contribute to society and pay taxes and generate income, you know, something goes wrong, you get a pressure injury or you know, your AD gets out of control, and getting back onto the system is much more difficult. So, yeah, that's another huge problem.
I'm going to bring the microphone over to Hanain over here. And while you're traveling over there, there's all of those major disincentives to getting back to work in the US as well. One of the things when I was doing a study about the facilitators and barriers to clinical trial participation, one of the barriers that came up was that people have a fear that they might improve enough to disqualify for assistance, which would prevent them from wanting to participate. So that's really important to know. Hanain.
There's also a big problem I see. I volunteer at Metro, and one of the main things that I see that is a big problem is that a lot of the caseworkers have no idea of, and if they do know, I don't know, they do not offer all these programs that are available to spinal cord injury. And when you're first injured, you're not worried about you. First of all, you don't know any of these programs and you have no clue. Your family has no clue. You're so drugged up by the time you make it home. If you're lucky enough, like I was, that I had a great entourage, whether it was my doctors or my social worker, I just hit the jackpot that the person gave me all the information. And now when I volunteer and the person's been in the hospital for 20 days and I'm like, did you fill out an application for waiver? And they're like, what's waiver? And I'm like, oh, that is very, and why are social workers not given that very simple application to these people is really, really a problem too. A big, there is the person right now in a nursing home, 26 years old, who was discharged 5 months ago. He wants to get out of the nursing home. Had they put an application, he would have had a case manager that came and did, and now nobody knows what's going on and he's stuck, and I'm just, hopefully I could help him enough to get him out, but it's just something that is doable, and unfortunately because someone just forgot to give that person an application, it's just not happening.
Can I ask, before you, Matthew, can I ask United Spinal to comment on this? Because with your partnerships with the different hospitals and regional chapters, I know a lot of them are integrated into the rehab hospitals. What can be done to try to help with that aspect?
That's really tough to handle through the United Spinal Hospital Network. We'd have to put some thought into how to possibly roll something out that could be effective to do that. And I say that first off because of how short rehab times were, and how much else there is going on. In my circumstance, maybe it's wicked long ago, I don't know, it was 20 years. I got injured in 99, and I was in for 3.5 months. When I came home, there was a bathroom where there hadn't been before, and, you know, everything worked pretty seamlessly for me, but that's not even remotely a possibility anymore because, you know, where are you gonna put somebody when they're coming out? Especially if they're on Medicaid, they might get 3 weeks as a para, maybe 4 or 5 for a quad level injury. There's not even enough reaction time. I think we need to do it. I think of the case managers and social workers that we run into, that we reach out to, or that reach out to us, it's always a good sign that they reach out to us. A lot of times, if we've got to reach out and beat the door down to get to them, they're not working that hard.
Yeah.
I'd like to see them all paid a little bit more and then fire them right away when they don't do the job. But
maybe we could collectively identify the different resources that you need in each state or in each province. Like
very important to do, and I would love to work
this is
towards
what
it.
you need to do. You have connections.
I want to give you a specific example to that. I think it was 2 years ago, in a legislative effort in Minnesota, one of the direct outcomes of that was the formation of a small nonprofit called Get Up, Stand Up to Cure Paralysis, in response to that sort of community organizing. And after the bill was passed, the group was started to have a different dialogue. Okay, what are some of the other, now that we've formed and we have a lot of people, what do we need to look at? One of the first things we did was we start to meet with the local hospitals and meet with their discharge nurses and caseworkers. And it was an obscenity like in some of the bigger systems. And we started that because it came out of our peer group and yada, yada, yada. And it was unbelievable what they didn't understand, what they didn't know, what they weren't giving people. And that's what led us immediately to adopt a project that Sam has put together, which is the first 90 days. And Gusu's rolling out a Midwest 90 days, which is a book that does exactly that. And Gusu immediately thought, well, this is genius. We were going to do this ourselves, but Sam's put it out in a couple spots, and I don't know if you want to describe it, or even if people know about it, but
yeah.
I started doing this in California, where I live. The idea being that people come out of emergency situations in a trauma center and they're completely clueless, and even after 3 months, they don't really know what's going on. So my idea was, I've been writing about spinal cord injury resources for a number of years, but I never really got granular about the very beginning part of it. What really happens in trauma centers. And then my goal was to get this information to people before they made a choice for rehab. Now, not everybody gets a choice, but you have one if you fight for it. And if you really fight for it, you can beat Kaiser and they'll send you to Craig Hospital out of California. So it can be done, but you got to arm people with the resources. Now, the first thing I did was, who are the people on the ground that already know about this? So the United Spinal chapter in Southern California, a big one, very healthy, called Triumph Foundation. They're my biggest distributor and my biggest resource disseminator, because they have arrangements with probably 20, 30 rehabs in Southern California. And they go there and they meet with patients. Now they're getting them a little bit late. They're getting them 2-3 weeks into their injury, but that's still very helpful in terms of challenging insurance, trying to understand the process of getting the resources and the tools you need to go home, and really importantly, to connect with their peers. who can really sort things out for you, tell who the good wheelchair distributors are, how to work, how to say it correctly to get reimbursed on certain things. And that's really, so I've developed this model. I did one in the Rocky Mountain states. I visited with Dale at his center, and we got Utah rounded up in there, and that includes the Craig Hospital was very supportive, very, and you know, with their backing, that book is getting distributed, and they actually have liaisons that are getting the books inside trauma centers because they're kind of recruiting in there, which, so they take the book and say, hey, look at this. And that, because they're saying, we're in it, and we're the big guys. So yeah, of course. So it's been great. So I did the Rockies, and then I did one specifically for Arizona, and then we just finished the upper Midwest, and you know, there'll be some other ones probably come. We're redoing the Southern California one now. I've learned a lot about how to be a little bit more focused on what people really need. And so that's a project that we're, you know, people have talked to me about doing them in Texas and New Jersey and Florida, and you know, maybe, I don't know how much bandwidth I have to do all that, but I'd like to keep doing
yeah,
it.
but these are resources that we need to connect with other people that can use it as a model, even if it's not for their particular
I'm all
state.
for that. And I think that there's an opportunity here with this organization and the umbrella you have to not only do that, but if you want to focus on your four principal problems there, you could own resource information. If you want to go into the literature and talk about what's going on with bladder and bowel and stuff, and you're talking about low-hanging fruit, I'm a low-hanging fruit harvester. I mean, that's what I do. I find information. I know how to find it. So that's something we could do. You could own it, brand it, and you could get it funded. United Spinal maybe helps fund it. Reeve Foundation maybe helps fund it because they can use it too. And it's important that, and then it starts to spread out a little bit. And maybe even Craig Hospital would get behind it because they just backed something Reeve did on going home, which is something that's a big part of what I do. How do you get ready to go home? Well, Craig just funded a really cool brochure with Reeve. So, you know, there's possibly funding sources for that. So maybe it's a project we could talk about as you start thinking about moving ahead.
Okay, Jane, and then Jane first, and then Dale, and then Christy.
So somewhat anecdotally, I've been hearing from a number of centers lately that they have real challenges in case management turnover. Seems to be a maybe growing issue, and I don't know what's behind that, but that might be something worth looking into more deeply. But also, just to let you know, United Spinals has seen a growing issue with people not getting into their spinal cord injury specific rehab. A lot of people going to skilled nursing facilities rather than inpatient rehabs. So we're looking at that more broadly, but as part of our approach towards that, one of the things we're doing is creating some fact sheets with the Model Systems Knowledge Translation Center on defining rehab and what those elements of rehab should include, so we can more clearly document things like that. You know, people need connection to their community resources and defining what some of those are. So that may be helpful when we have it finished.
Yeah. Dale, here, right here.
I've had this sense of anxiety most of the day in this meeting. And I've been trying to figure out what it is. First of all, I mean, this is my first appearance at this meeting. And I want to say, I think it's an amazing concept. I think you're onto something. But I've been trying to figure out what my anxiety is about. And I think at the risk of sounding like I'm going to throw stones, I don't want you to feel that way, but my anxiety is that we've all been talking about a lot of problems, and we all kind of, to some degree, we're very good at wallowing in the problems. I guess my question is, what does this organization want to be? And that's what my anxiety is, because I think this organization could be a force majeure if it wants to be. But it's going to require that instead of just continuing to talk about the problems and suggest certain things, you're going to have to be very specific and deliberate about identifying the problems on a whiteboard and then ranking them and triaging them, creating a strategic plan, and then saying, okay, now let's all brainstorm. How are we going to solve the problem? Here's problem number one. Here's the top priority. How are we going to solve it? And if that's the only thing you do in 1 year, you'll change the world. I'm going to recommend a book that I just finished reading. It's called The Power of Moments by Chip and Dan Heath. It's an amazing book because, for example, they talk about the sit-ins in Tennessee that happened during the civil rights movement, where the college students went and sat at the lunch counter, right?
Mm-hmm.
What I didn't ever know is that there was a black pastor who trained those students how to behave and how to act when the police came, very specifically, put them through scenarios time and time again so that their response would be exactly what they needed to move the whole civil rights action forward. They couldn't be violent, they couldn't be obscene, they had to be courteous. But what I didn't realize is that was a calculated, planned strategy in terms of what they did.
Mm-hmm.
That's what we need with spinal cord injury. There are plenty of problems, but we need a planned strategy with specific steps, with specific partners who have the specific talents and abilities and resources to solve that problem, and then we move to the next problem. I don't know if that's what this organization wants to be. I would love to see that happen because I think you could do it.
Yep. And I think that we are in a stage, and remember, we're only just under 2 years old, that we are in this talking about what are all the problems and starting to develop the players. And the goal of this is to try to start to develop those action items. And, you know, it's a big spider web strategy, really, to try to fix all the problems in the system. But yes, how do we start going about each specific problem and in a strategic way to answer it and tackle it? Christy first.
So I'm going back to the discussion about access to care and the awareness of case managers about resources. And so part of this is an advertisement for the spinal cord injury systems of care within the Department of Veterans Affairs, because there are tons of veterans who get spinal cord injuries who are not using the VA for care at the time of their injury. And there's a huge lack of knowledge that for most of them, they will qualify for VA care just on the basis of their spinal cord injury after that happens. But they're not always getting into our system. And they're ending up maybe in a nursing home instead of in the VA. And so they have bad secondary health complications. And I think that if we can improve the knowledge about using the VA, and if we were to get all veterans with spinal cord injury that qualified into the VA, we might be able to use their outcomes and compare them to the outcomes of people that are getting care through the, you know, the normal private sector or Medicare or Medicaid, and say, look, if we're doing this better, when we get people within, say, 2 days, 3 days of their injury, once they're, you know, through their surgeries, then I think that might have power to translate into regulations that say that everybody needs to get that quality of care.
Barry, and then do we have some other people that were wanting to make comments?
Dale, you're not alone, okay? I just wanted to say that that anxiety is absolutely warranted, and Kim and Jen will tell you that they have a phrase, Barry, stops, you got to get out of your head, because I have gone through this so much in a good way, just rest assured, I just want you to know that we're very mindful of trying to take on the world in 100 different ways. And the way I've put my head on the pillow every night on this subject, and I've thought about this a lot, is that the strength of what we could, really the secret and the sauce for us is to rely on our partners and let those on the ground do so much of the things that we're talking about in solutions for today, and staying in our lane. And our lane is on the mountaintop, but to make sure that the mountaintop is still communicating with the people in the villages. And I think, I just wanted you to know that that is absolutely a thing that we have to keep in mind all the time. So rest assured, we are thinking about that. of not trying to bite off more than we can chew and really not be effective in any way. So we are just still in the midst of figuring that one out, but thank you for that comment.
And actually, I knew that this session was going to turn into that, and I had a lot of anxiety about it because I'm not just about talking, I'm about acting. But I think we need ideas. We need to know what are all the problems, and then having the right players. Megan.
It does make the world of problems seem huge because we're kind of listing them off, but at the end of the day, doesn't it seem like everything rolls up into a couple of big categories? Maybe it's making sure people survive their injuries. Have we moved the needle on that in the last 20 or 40 years? Maybe we have. Are people who have a spinal cord injury, are they living longer? Have we moved the needle on that? And why haven't we? If they're living longer, do they have comorbid problems that we could be reducing? Are they getting full access to the technologies and basic equipment that they need? Like, I like to think of it as like moving the needle. Have we moved the needle on some of these things in the past 20, 30, 40 years? And if we haven't, what's behind all that? Because we might just want to pick the biggest bang for the buck issues and then focus on those.
I would say to try to get the energy levels up here, if we're just going to extend our lifespan, I don't want an eternal lifespan in hell without having a better life and better access to things and less worry about things. Right. Bill?
So Kim, thinking about the way I've seen United Spinal approach things over the years has resulted in some good programs, some good deliverables. We're very proud of our hospital backpacks that come pre-loaded with educational information and driven by sponsors, so they get the sponsor contact info in there, and that's how everything works. We're delivering 5,000 of those to rehab hospitals to hand out to their patients. Are they handing them out? Sometimes. Times are so short, if one hand doesn't know what the other hand in the hospital's doing. Sometimes I'll be on the phone with somebody and they'll say, don't you guys have a hospital or a wheelchair backpack program? And hold on a minute, I'm looking them up and he goes, yeah, Dana Jones is our contact. Oh, I know Dana. I didn't know we got our backpack. Like, they have no idea what's going on inside that hospital. And I believe Sam touched on it briefly, and I am not familiar with that writing. I am going to be here very shortly. But you mentioned along the way trauma centers, and I think that's where the Holy Grail is, because the rehab experience is like lightning now. If somebody's in there 3-4 weeks, they're barely seeing what ends up, and the family takes a while to come out of the state of shock before they can start thinking of what they have to do next, and let alone have time to get a home remodeled. So now they're in a nursing home waiting when they get out of rehab. The trauma centers, I would have thought that a level 1 trauma center would have known where to send somebody for rehabilitation after a spinal cord injury. They don't seem to, as a group. I'm working directly with one near where I live. We, in the chapter folks, sought the relationship and working on it. And they have their own little generic rehab a floor down, which I found out surreptitiously from the social worker that, oh yeah, people are here like 7 to 10 days and we send them home. Okay. I got resistance. We're welcomed to come in to do peer support and guide people in the right direction who had a spinal cord injury. But then the director's back stiffened, and I got some definite resistance when we would tell families, well, you need to go to an SCI unit. Downstairs isn't going to cut it. You do what you want. But if you go north 2 hours to VCU, where they do 70 patients a year, and now they're combined up there is going to do 114 when their new facilities completed, or you go down south into North Carolina to Greenville, where they do 50 a year. Every single person you deal with, from the people bringing food from the commissary, know how to work with people with spinal cord injuries. But if you go downstairs, they do 5 of them a year, so they don't really know. This isn't what they do. You're not exposed to any sports programs. You're not exposed to anything in a community. You're in there 7 days, send you home, and you're lost. So to get into all the trauma centers with well-developed guidance about what is supposed to be, and we're starting to work on that, what is supposed to be a good component of a rehab experience, and then get them to refer those people there, then more people have a chance. The denial of rehab percentage now is horrendous.
I think we have one more comment question back here, and then I think we'll tie it up onto our final.
So who do you approach to get the information out if there is a gym that's available? Because I go to a gym that is handicap accessible. The owner is Chris. No one has given me that information when I was at Metro. And that's so helpful to me because I go there literally every day. Everything's accessible. It's so affordable. It's less than $45 a month. If you can work out on your own as a paraplegic, if you're a quad, they have a trainer there. And it's but I just happened to be at Metro post my injury, and some guy in a wheelchair approached me and asked me and told me the information. And I'm wondering, why isn't this information just everywhere? At Metro, the VA, to give the option to the people, and if they decide to work out, then they have it. If they don't, then, and it's really heartbreaking just to see that.
Yeah, I think we need to start working on, that's where we need to start working on the local levels.
And just to let you know that I have made that information available to the various different medical facilities. So, I've passed it on to social workers and other people, therapists. The information is available that we are a resource for an after therapy type approach. So, I don't know where the disconnect is, but it doesn't get into the right hands.
I'm a big proponent of getting things straight into the hands of the people living with spinal cord injury, because that usually ends up being the most effective way. So thinking up more strategies of ways to do that, I think, is what we need to do on a national level, but also on a micro, local level.
Can I really quick just say,
Mm-hmm.
just so you guys know, or you may not have heard it yesterday or the day before, but that's one of the reasons why U2FP over the last 2 years sort of catalyzed this forming of an association, activity-based therapy centers, of which there are 50 to 60 across the country. And they met in that room yesterday, about 12 centers represented. The association is formed, and part of the agenda is there need to be more of them. There needs to be better access. They need to not be expensive. They need not be a burden. They need not only be used by people who have resources that are middle and upper middle class, all those sorts of things. And so that effort has legs and is now moving. That association, I'm confident, will grow, and is also looking at how do we address compensation as this get paid for. That's all a part of that association, as well as elevating clinical practice, elevating business practice, all of those pieces, because we recognize the real need for it.
All right. Oh, one last comment. Oh, we have 2 comments. You're not dying to get out of here yet.
Thanks. So we spent a lot of time today talking about problems, and we heard a little bit about solutions. I think there's a way more solutions out there that have been developed that we need to do a better job of mapping them, sharing them, so that then they can be adapted to different geographic contexts and scaled up. So I think that would be something that this organization could have tremendous impact on.
That's definitely
We're not good. We're spread out so far in North America. we're not good at working outside of our little silos.
Yes.
And this would be a way to start sharing more of these unique solutions that have developed that work really well.
That is definitely what we want to do in the very short term. All right. So we're 5 minutes from a drink reception. And I just want to go over the nominations for elections, and everybody has a form on their table. And this is just to introduce the concept. We'll also be sending out this information to the full membership. And so any representative of SCI-led organization, that's the principal member category, and any individual or family member with spinal cord injury, so our patron members, can run for elections. One of the core things of NASCIC is that we wanted to keep it in the hands of people with spinal cord injury, so our partner members are not allowed to run for elections, but we do enable ad hoc input at all times. So just to talk about the nomination, we go forward one, Megan. I mentioned that we had become very busy this year. And so the normal way that we outlined our governance is that someone would be elected for vice president, they would serve that term for 2 years, and they would automatically go forward to president, serve that term for 2 years, and then go forward to past president and serve that term for 2 years. So I am technically supposed to be going to past president now as of January 1st. But because we had a very significantly steep slope of growth in our projects, which is what the vice president is responsible for, John decided he wanted to step down, and so we appointed Jen as an interim until the end of December. So we need to elect a new vice president that will go forward for 2 years, but we are without a president. And so the executive council asked me if I would be willing to stay for another 2 years as president, but we are going to put that out for election in the membership instead of it just being an appointment. And if that is the case, then I will stay for 2 more years because I don't want to see the momentum stop. But next thing forward is that there will be an opening for a new vice president. And like I mentioned, that's really a 6-year commitment. So it's really important to think about that. I know that we're all very busy people, and we're actually trying to engage more and more people in our community that are not necessarily as busy. So that's how we are going to develop the sustainability of NASCIC. But we are a very early grassroots organization right now. So the vice president is really, their primary responsibility is being involved with projects and managing all of the project system, and then grooming that person to take care of the rest of the things that the president does when they come on as president. And next, we wrote into the charter that we wanted the treasurer to just have a 1-year term, but it could be reelected without any term limits. And so Barry has been our treasurer for the last 2 years, and he's been doing a really incredible job. But if anybody wants to nominate themselves, that is open out there. I know I am going to nominate Barry to keep doing it. But that is how we wrote that in. And then lastly, we have 3 new delegate positions because we won't be having a past president position yet. And Matthew is going to be rotating off, Bill is going to be rotating off, and Rob Woodlick is going to be rotating off, and Sasha still has 1 more year. And so we're trying to stagger these so that every year we have a new person coming on via the delegate representation and a person going off, so we can have infusion. But this particular year, we're going to actually have quite a few elections coming in. So we will be seeking nominations. You could write down names here if you want to, but I am going to send all of this information out to our full membership to solicit nominations, and their, self-nominations are okay too. And then probably at the end of November, beginning of probably end of November, we'll have the elections and have the new results ready to institute in January 1st. Dale. Mm-hmm.
So one idea would be to have a president-elect. President-elect serves for 1 year before rotating to president, and then 1 year after the president has been. I think the vice president is able to turn over quicker because that person has all those program responsibilities. So it doesn't feel like such a heavy burden that gets shouldered by how many programs from the long term.
Yes, and when we wrote our charter, we wrote it like this, but we wrote that we would evolve over time, so we can change the charter over time. And the other goal is that we are trying to become financially stable enough so that we can actually hire an executive director full-time, so that takes the load off, some of the load off of the volunteers. It doesn't take all the load off because you have to have the vision to keep the organization moving forward. But yeah, I totally understand that burden. All right, so Barry, you have the information on the reception and the drinks. Oh, go forward, one more thing. I want to, can you clicker? I just want to, again, thank our sponsors and our supporters of the Nielsen Foundation from our infrastructure grant and the sponsorship of this meeting and enabling it to happen, because these are really people that have faith in us for a brand new idea that, you know, I think I said it to someone else, we're all flying by the seat of our pants here because this didn't exist before. And so we're really trying to evolve over time, and we're very thankful for the people that have faith in us to be able to accomplish this task.